Hey, Jeremy Hammond here, and in this video I want to talk to you about the political response to the 2019 novel coronavirus, and I want to talk to you about what you need to know about the fatality rates. This is the third video in a series that I'm producing. The first one was just a brief introduction explaining my purpose and the focus of this series. And I was asking the question of how, first of all, how do we get to where we are today in terms of the political response with these extreme measures being taken place that are causing such incredible harm to the economy, and then where do we go from here? The second video looked at the Imperial College model that was so influential, and in pointing out how these measures have politicians implementing these measures have no exit strategy, at least no feasible, realistic one. So if you haven't seen those, you might want to pause this video and go back to my website, jeremyrhammond.com/coronavirus, and I've got all the videos in this series will be on that page. So if you haven't seen those, I encourage you to pause this one, go back and watch those two to get that context. And with that said, let's proceed. So first, here's what the public was told about the fatality rates for coronavirus. On March 3rd, the Director General of the World Health Organization said that, quote, globally, about 3.4% of reported COVID-19 cases have died. By comparison, seasonal flu generally kills far fewer than 1% of those infected. And that figure, that 3.4% figure, was very widely reported at the time, and still even today. Another quote here from Anthony Fauci, who is the director of the National Institute for Allergy and Infectious Diseases at the National Institutes of Health, on March 11th, told members of Congress that, quote, the flu has a mortality rate of 0.1%. This has a mortality rate of 10 times that, this meaning the novel coronavirus. So in other words, he's saying that the mortality rate is 1%, which is downgraded, a lesser mortality rate than the 3.4% cited by the WHO previously. However, even that, I will argue, is inherently overestimated, and I'll explain exactly why. So the models that have been relied on by policymakers as justification for these extreme measures incorporated fatality rates that were inherently overestimated. So some terms to know: one is case fatality rate, or CFR abbreviation, which is deaths divided by cases. However, frequently there's no real firm definition of the case fatality rate, and so oftentimes cases, it just in the denominator is just reported cases, as opposed to the true number of cases there are, the true number of infections. And so sometimes scientists actually distinguish between a case fatality rate and what's known as an infection fatality rate, or IFR, which is deaths divided by estimated infections, or possibly actually measured infections. So if testing is actually done in a population to actually determine the rate, then well, that's still an estimation, but because they can't test every single person, but they do a sample and then they estimate the rate of infections that way. I'll talk more about that later. So there are numerous factors that affect the accuracy of both the numerator and the denominator in a case fatality rate. The reported fatality rates and relatedly hospitalization rates are inherently overestimated, as I'll explain. And the WHO Director General and Fauci deceived the public by failing to properly qualify their statements and explain what those fatality rates actually mean. The effect of this is to cause fear and panic among the public, and also to put pressure on politicians to do something. Of course, the question is, what do we do? And are the policies based on fear and panic, or on the science? The models predicting massive numbers of deaths and hospitalizations were used to justify extreme and harmful authoritarian policies. So let's look at some factors affecting the numerator. There are various factors that can bias the numbers either upward or downward, in other words, over or underestimation. So an example of a bias that might, bias the a factor that might bias the number downward or toward underestimation is that early in the epidemic, clinical outcomes are yet unknown, and so you might have like a certain number of cases, but death lags cases, and so we don't know actually how many people actually die who become infected and then actually die. And so early in the epidemic, this can cause the fatality rate to be underestimated. However, in time, as more data is collected, this becomes a non-issue. Another example of a factor that can bias the number downward is that some deaths may not be recognized as due to COVID-19. So somebody might die and nobody connects that with the virus, and so that their death isn't counted as a COVID-19 death. However, when considering this potential bias, we also need to keep in mind that severe cases requiring hospitalization and intensive care are precisely those most likely to get tested. So looking at some of the factors that put upward bias on the number, here's one: is failure to distinguish deaths with SARS-CoV-2 from deaths due to COVID-19. And so I'm using those two terms there precisely because in the media and even public health officials are not using those terms precisely. So just to clarify, SARS-CoV-2, so the SARS coronavirus, number 2, is the name of the virus, whereas COVID-19, coronavirus disease 2019, is the name of the disease caused by the virus. So there's a distinction between those two technically. So those are the technical definitions. And so I'm just being precise here in the language. And so what I mean by this is that just because someone dies and they were tested and found to be infected with the virus and then they die, doesn't necessarily mean that it was the virus that killed them. That may be a reasonable presumption, but it may not necessarily. Another upward biasing factor is the presumption that deaths are due to COVID-19 without lab confirmation. And this is a big one, so I'm going to focus on it mostly here. So presuming deaths are due to COVID-19 without lab confirmation, the WHO actually introduced a new International Classification of Diseases, or ICD code, for COVID-19. And so one of them is for lab confirmed cases. So they've done a test and they've confirmed that there was infection with this virus, and so that's a lab confirmation. And the second code is for cases where there's suspected or presumed cases without lab confirmation. And it makes sense to distinguish between the two so that researchers can parse the data. However, in the US, the CDC on March 24th issued new guidance to use only a single ICD code for COVID-19. And here's a quote from a guidance document from the CDC, and guidance for certifying deaths due to coronavirus disease. It was put out in April, which is this month. And here's the quote. Here's a quote from that document. So, pneumonia is important to report in a cause of death statement, but generally it is not the underlying cause of death. The cause of pneumonia, such as COVID-19, needs to be stated on the lowest line used in Part 1. Additionally, the reported underlying cause of death should be specific enough to be useful for public health and research purposes. For example, a viral infection can be an underlying cause of death, but it is not specific. A more specific underlying cause of death in this instance could be COVID-19. So the point I want to make here is that, in these statements, the CDC could easily have replaced COVID-19 with influenza, for example. So it's almost as though, a not unreasonable interpretation of this is that the CDC is suggesting to medical professionals that if you don't know, if you suspect viral infection was an underlying cause of death, but you don't know the specific virus, then just call it COVID-19. Just presume that it was COVID-19. which, depending on the symptoms and other factors, may be perfectly reasonable to make that presumption. But in other cases, it's not, because a lot of the symptoms, many people present with symptoms that are very similar to flu. In fact, COVID-19 is being categorized among a wide variety of illnesses known as influenza-like illnesses. So that's a technical term, an abbreviated ILI, influenza-like illnesses, which I'll come back to. So unlike influenza, so this policy of the CDC's is unlike their policy for influenza, for which there are different ICD codes to distinguish between lab-confirmed and presumed cases, which allows researchers, again, to parse the data. Another important point is there are at least 200 known viruses that cause, again, what are known technically as influenza-like illnesses, or ILI. Lab testing is usually not done, and the CDC instead uses mathematical models to estimate incidence and deaths. They don't, when you read in the media about the reports of flu hospitalizations and deaths, they're not citing the statistics from the ICD codes. They're not referring to what's on death certificates. They're referring to the CDC's mathematical models. This is an important caveat to all of this data in terms of comparisons to influenza. So CDC has estimated that since 2010, there have been 9 million to 45 million cases per year of influenza, 140,000 to 810,000 hospitalizations per year from influenza, and 12,000 to 61,000 flu deaths per year. And so they're providing a range because it varies greatly year to year and, in fact, decade to decade. So if we look at just the death certificates for flu, we have from 1999 to 2018 lab-confirmed cases of influenza-related deaths numbered just 1,061 on average. And that data comes from a database known as CDC Wonder, which is right on the CDC's website. From 1999 to 2018, the same 20-year period, lab-confirmed cases and presumed influenza-related deaths together, combined, numbered just 2,615 on average. And there's the website where you can go and punch in the criteria and confirm those numbers for yourself. That's wonder.cdc.gov. So returning again to that guidance document from the CDC, there's an interesting quote in there. They say, appropriate completion of death certificates yields accurate and reliable data for use in epidemiologic analyses and public health reporting. I find this an interesting and curious statement, given the fact that the CDC, again, they don't cite these numbers when reporting flu deaths and hospitalizations each year. They instead use mathematical models. So why is that? If the ICD coding system yields accurate and reliable data for use in epidemiologic analyses and public health reporting, then why do they need to do these models? And there are some legitimate reasons for that. I'm not denying that. However, the point that I want to make here is how the CDC deliberately uses fear as a marketing strategy to promote influenza vaccines. And just to prove that to you, there's actually a CDC document that presents a recipe to use fear to control people's behavior and manipulate people's behavior. So this was the document. It was a presentation titled Increasing Awareness and Uptake of Influenza Immunization, presented by Glenn Nowak, who is the acting director of media relations at the CDC. And this was presented to an Institute of Medicine workshop on June 17th, 2004. And I initially got this document right from the National Academy's, the Institute of Medicine website, which has since become a dead link. They removed it. However, what I've presented here is a web archive version of that document. So looking at that document, the CDC presented a recipe, their word, a recipe for fostering public interest in high vaccine demand. And so they called for medical experts and public authorities to publicly, quote, state concern and alarm and predict dire outcomes and urge influenza vaccination. Again, they urged medical experts and public health authorities to frame the flu season, quote, in terms that motivate behavior. Example given as very severe, more severe than last or past years, deadly. Some implications of the recipe are that fostering demand, particularly among people who don't routinely receive an annual influenza vaccination, which is typically like young, healthy adults who recognize that they're not in high-risk group. So fostering this demand, quote, requires creating concern, anxiety, and worry. The mass media is unhelpful toward the CDC's goals because there are hundreds of websites offering medical and health information. And so people are out there consuming information. They're not getting, their information necessarily just from the CDC and public health authorities. They're out there doing their own research and learning about the science and learning about health and how to control their own health and taking matters into their own hands. And so the CDC views health literacy, quote, as a growing problem. In other words, people who do their own research and think for themselves and learn about health and science and health science, that's an obstacle in terms of the CDC's public health goal of increasing vaccine uptake. So coming back to this point about presuming deaths are due to COVID-19 without lab confirmation, some other problems with that is that there may be reporting bias during pandemic years, and there are some indications of that from the past. For example, in the 1976 influenza AH1N1 swine flu scare, there was dramatically increased reporting, such that deaths attributed to influenza for males increased 966%, and for females 896%. The pandemic, by the way, never occurred, even though there was a vaccine that was mass-produced that year, and I don't know the numbers, but many, many people, probably, I'm assuming numbering in the millions, received that vaccine. And again, the pandemic never happened, so they were unnecessarily putting themselves at risk. Everyone who got the flu shot that year, that pandemic version of it, was putting themselves at unnecessary risk of harm from the vaccine for no possible benefit. And that vaccine did turn out to have been associated with an increased risk for what's known as Guillain-Barré syndrome, or GBS, which is a polio-like paralytic disease. In fact, some scientists believe that Franklin Delano Roosevelt did not actually have polio. He may have had, it's more likely that he had GBS, in their opinion. Again, in 2009, with the pandemic influenza AH1N1, it appears that there was this reporting bias due to the pandemic. And I'm using the word pandemic here in quotation marks because the WHO that year actually redefined what a pandemic is by eliminating the severity of the disease as a criteria. And as it turned out, that strain of the flu was no more severe than the seasonal flu. So it's another issue. However, some researchers, I'm getting this from a study, and they say that, quote, the use of influenza on death certificates seem to reflect its presence in the medical news. In other words, when there's a lot of news about some pandemic illness and there's a lot of fear and panic and stuff about this illness, that influences medical practitioners, that biases their view of what the underlying cause of death might be. And so they're more likely during those years to just attribute the death to that particular virus. And so that's my source for these figures here, this information. Is a study in biodemography and social biology published in November 2013. So to come to the denominator and some factors affecting the denominator, there's really just one big glaring one, which is that the reported fatality rates have typically only included the reported cases in the denominator. And so until very recently, they've only used what are known as polymerase chain reaction assays, or PCR assays, to detect cases. And so what this is a test that actually it will determine whether it looks for the genome sequence of the virus. So it actually will look and see whether that virus is actually infecting the body. And so the problem with this is that it only can tell you if you're currently infected. What it can't do is tell you whether somebody had the virus, recovered from it, developed immunity to it, and now is no longer infected. And there's also an ascertainment bias with this type of testing because typically due to just the lack of tests and just the way that policies have worked, they typically have been given, they only are testing those people who come to the hospital and have more severe disease. So if you only test the people with more severe disease, naturally among those people the death rate is going to be higher than if you were to consider all the other people who have mild disease or no symptoms at all. And so by excluding all the milder cases or asymptomatic cases from the denominator, you are overestimating the fatality rate. So randomized serological testing is required to determine the true prevalence of infection among the population. And so serological testing is different. It doesn't look for the genome sequence of the virus. Instead, it detects antibodies that your immune system creates in response to the virus. And there are different types. And so one type of antibody, for example, will tell you whether you're currently infected, and another one can tell you whether you were infected in the past and have developed immunity. Or not necessarily whether you've developed immunity, but it will tell you that you have been infected in the past and that you developed antibodies to the virus as a result. So case fatality rates based on PCR testing with ascertainment bias are inherently overestimated. And so I want to now kind of shift gears a little bit in terms of, so that's what you need to know in terms of just understanding, fatality rates and certain caveats and things that you need to know when you see fatality rates reported in the media. So now I want to kind of look at the accumulating evidence that these fatality rates are not just overestimated, but that they're overestimated by orders of magnitude. So again, looking at the WHO statement, 3.4% of COVID-19 cases have died. So they're saying that that's the fatality rate in comparison to the flu. That was set on March 3rd again. But if we look at CDC data for the 2019 to 2020 flu season for the week ending of March 7th, which was the week that the Director General of the WHO made that statement, we can see that there were 7,641 influenza deaths reported in the U.S. at that time. There were 43,872 influenza positive cases in the U.S. So if we were to take a more equivalent comparison, we would see that there was 17% of reported influenza cases that died. So imagine if the WHO had said globally about 3.4% of reported COVID-19 cases have died. By comparison, 17% of reported influenza cases in the U.S. this season have died, which is a more equivalent comparison than what the WHO Director General made. And obviously the fallacy of that is that you're only looking at reported cases of influenza as opposed to actual numbers of infections. So what Congress was told by Fauci on March 11th, 2020, again, was that that COVID-19 has a mortality rate 10 times that of influenza. So 1% fatality rate as opposed to 0.1%. But here's what he knew when he made that statement, and also CDC Director Robert Redford knew at the time. That, quote, if one assumes that the number of asymptomatic or minimally symptomatic cases is several times as high as the number of reported cases, the case fatality rate may be considerably less than 1%. This suggests that the overall clinical consequences of COVID-19 may ultimately be more akin to those of a severe seasonal influenza, which has a case fatality rate of approximately 0.1%. And that's what he wrote, along with co-authors Lane and Redford, in a New England Journal of Medicine paper on published March 26th, titled COVID-19, Navigating the Uncharted. Here is a paper published March 19th in the International Journal of Antimicrobial Agents, titled SARS-CoV-2, Fear versus Data. This was done by a group of French researchers who compared fatality rates of common coronaviruses with SARS-CoV-2 among hospitalized patients in France and other developed countries. Again, this is a more equivalent comparison. They're not comparing the infection fatality rate of common coronaviruses. In other words, the number of deaths per estimated infections. They're looking at hospitalized cases. And so they note that common human coronaviruses cause 10 to 20% of respiratory infections worldwide. At least half of COVID-19 cases are asymptomatic. And that in addition to coronaviruses, there are 16 endemic viruses in common circulation. They also point out that recent years have seen 2.6 million deaths per year from respiratory infections globally. Their findings show that, quote, there does not seem to be a significant difference between the mortality rate of SARS-CoV-2 in OECD countries and that of common coronaviruses. And it's an important caveat here to note that they're talking about developed countries where there's good health care and good access to health care. So this might not apply for developing countries, but they looked specifically at France and other OECD countries. They also found that, quote, SARS-CoV-2 infection cannot be described as being statistically more severe than infection with other coronaviruses in common circulation. Additionally, quote, in OECD countries, SARS-CoV-2 does not seem to be deadlier than other circulating viruses. Another paper published in the European Journal of Clinical Investigation on March 19th by John I don't know how to pronounce his last name, but my best guess is Ioannidis, who is a very well-known scientist, a very well-respected scientist. In fact, The Atlantic magazine has described him as one of the most influential scientists alive. And he's written a paper that's one of, if not the most widely cited paper in all of the medical literature. And he's most famous for his research into just how bad most science is. For example, researchers' conclusions don't actually follow from their findings and this kind of thing. And so he's done a lot of research into that. And so in this paper, he pointed out that the challenge of the pandemic is being compounded by, quote, exaggerated information that can, quote, lead to inappropriate actions. And of course, he's talking about government policies. He pointed out that the most widely reported case fatality rate was the 3.4% cited by the WHO, but that this, quote, ignores undetected infections and the strong age dependence of CFR. So that's a really important point, is that it's not as though everyone in the population has an equal risk of severe disease or of death from the coronavirus. And so younger people have a very much lower risk. Children, the risk is almost negligible, whereas elderly people have a much higher risk. And specifically, it's not just age, it's not just that being old puts you at risk, but that people who are elderly and have comorbidities, so people with other underlying diseases, so people with cardiovascular disease, lung disease, kidney disease, diabetes, obesity, other illnesses, those are the people who are at the highest risk. So it's another important factor. So this case fatality rate, should be thought of in terms of it doesn't tell you everything you need to know. That it's in the virus itself is just one risk factor. So just because you get the virus, just because you get infected, doesn't mean that you have this risk of dying. It varies per individual. So the extreme measures that have been adopted by many governments around the world, including I'm coming to you from Michigan here, where the governor has implemented extremely authoritarian executive orders, which in my view are unlawful and unconstitutional. But these measures, he pointed out, they're lacking scientific evidence. And he actually cites a systematic review of the medical literature on mitigating measures for pandemics. That includes, they also examined social distancing measures, and they found that there was very little scientific evidence to support social distancing measures, whereas they found strong evidence to support common sense things like washing your hands, not touching your face, things like that. And so he also wrote, quote, maintaining lockdowns for many months may have even worse consequences than an epidemic wave that runs an acute course. So, of course, he's talking about the economic harm from these measures, which also it's not just about the money and the finances and in driving people toward financial ruin, but there are health costs to that. There will be costs in lives due to the authoritarian measures And so, those lives also need to be taken into account. In the Wall Street Journal on March 24th, a pair of researchers wrote an article titled, "Is the Coronavirus as Deadly as They Say?" These were Stanford University professors of medicine. And they noted that fear of COVID-19 is based largely on a high estimated fatality rates ranging from 2 to 4%. And, I've seen rates reported by the media even higher than that, 6%. Just the other day in the New York Times for talking about different rates in different countries. However, they pointed out that selection bias means these numbers could be orders of magnitude too high, and that accumulating data indicate that that's the case. So assuming an epidemic seeds at the beginning of the epidemic on January 1st, 2020, this implies that 6 million infected people in the U.S. have been infected by March 9th, giving a fatality rate of 0.01%, or 1/10 that of influenza. And they stated, quote, "A universal quarantine may not be worth the costs it imposes on the economy, community, and individual mental and physical health. We should undertake immediate steps to evaluate the empirical basis of the current lockdowns." Another paper published March 26th. This was a preprint paper, meaning that it hadn't undergone peer review yet and hadn't been published in a peer-reviewed journal yet, but it was published in a preprint publication. The title of the piece was "Fundamental Principles of Epidemic Spread Highlight the Immediate Need for Large-Scale Serological Surveys to Assess the Stage of the SARS-CoV-2 Epidemic." So this was done by Oxford researchers who modeled the epidemic in the UK. And they pointed out that there's an inverse relationship between the proportion currently immune and the fraction vulnerable to severe disease. This relationship can be used to determine how many people will require hospitalization and possibly die in the coming weeks. In other words, we need to know the true infection rate, because without knowing that, the data is not reliable and can't be used to determine policies. I mean, we need real data to determine policies, as opposed to policies being based on fatality rates that are inherently overestimated. So in other words, policy making that's based on fear as opposed to science. So their model suggested that the epidemic had started at least a month before the first reported death and had quote, already led to the accumulation of significant levels of herd immunity. Their model also suggested that by March 6th in the UK, assuming an R0, or a reproduction number of 2.25 or 2.75, which I'll explain in a moment, that 60% to 64% of the population, respectively, had already been exposed. So the R0 is a number, it's called the reproduction number. And the meaning of it is so that with 2.25, for example, so for every person who gets infected, every individual who is infected, they will then expose and infect 2.25 additional people. And so there's an exponential growth in terms of the spread and transmission of the disease. However, we have to keep in mind that this exponential growth doesn't continue indefinitely, which is why, for example, with the flu, we don't see that the entire population, 100% of the population, is infected every year. In fact, only maybe something like 8% of the population actually experiences influenza during any given season. And so why not? Well, it's because we have population immunity, and so influenza can evolve to evade immunity, and it does so very rapidly every year. It goes through evolutions that help it to evade immunity to an extent. However, there still remains a large cross-protective immunity among the population, and so there's this population immunity that keeps that reproduction number lower. So we need to consider, we're talking about a naive population here in terms of SARS-CoV-2. So these researchers also, what they did was they did randomized serological testing, or they pointed out rather that this type of testing is required to determine the true prevalence and hence to inform policy making. And Reason magazine on March 27th commented on the study by saying that if these findings are true, that, quote, the CFR for COVID-19 in the UK would be something like 0.002%, making disease much less deadly than the seasonal flu, which has an estimated CFR of 0.1%. In the BMJ, the former British Medical Journal, formerly called the British Medical Journal, on April 2nd, Michael Day wrote a paper called COVID-19, 4/5 of cases are asymptomatic, China figures indicate. So he's talking about data from China showing that, the majority of cases don't even have any symptoms. Not just mild, but no symptoms at all. And so he quoted Tom Jefferson, who's an epidemiologist and honorary research fellow at the Center for Evidence-Based Medicine at the University of Oxford, also formerly a top researcher with the Cochrane collaboration. And Tom Jefferson said, quote, the sample is small and more data will become available. Also, it's not clear exactly how these cases were identified, but let's just say that they are generalizable. And even if they are 10% out, then this suggests the virus is everywhere. If, and I stress if, the results are representative, then we have to ask, what the hell are we locking down for? I think that's a good question. Jefferson, along with a co-author at the Center for Evidence-Based Medicine, published an article titled COVID-19, The Tipping Point on April 8th. And they also pointed out the inherent ascertainment bias with reported case numbers, and that there's little doubt that SARS-CoV-2 is far more widely circulated than popularly believed. And they wrote, quote, nor can there be little doubt that the price of lockdown to society and economic paralysis is likely to be paid for generations to come. In the short term, economic devastation seems certain, imposing a heavy penalty on us and probably successive generations. So obviously we need to factor that into our consideration in terms of policymaking. They cite a New England Journal of Medicine article written by an Italian doctor describing his experience in northern Italy. And this quote doesn't come from Jefferson and Hennigan's paper at the Center for Evidence-Based Medicine, but I just looked up the source and I found this quote from that New England Journal of Medicine article. And so that Italian doctor had written, quote, we are learning that hospitals might be the main COVID-19 carriers, as they are rapidly populated by infected patients, facilitating transmission to uninfected patients. And so Jefferson and Hennigan, citing that paper, pointed out, quote, an older person admitted to hospital runs the risk of never seeing the light of day again. This is probably the clearest message coming from Italy. And they also reiterated the Italian doctor's suggestions about how to deal with pandemics, suggesting that more mildly symptomatic individuals should stay at home. And that also, obviously people who have more severe symptoms, yes, definitely they should seek health care, but at the same time there should also be a change in emphasis from hospital to home care. And for those requiring care, and if this was to happen, if there was to be a shift in the whole paradigm of pandemic preparedness and response, it could, quote, avert a disaster for the wider population. And they also wrote, quote, lockdown is going to bankrupt all of us and our descendants and is unlikely at this point to slow or halt viral circulation, as the genie is already out of the bottle. What the current situation boils down to is this: is economic meltdown a price worth paying to halt or delay what is already amongst us? Another preprint study, very interesting one, titled Using Influenza Surveillance Networks to Estimate State-Specific Case Detection Rates and Forecast SARS-CoV-2 Spread in the United States. So these researchers pointed out that PCR testing has undercounted the true prevalence of SARS-CoV-2. And he noted that, quote, estimating the true prevalence informs the scale of upcoming hospital, ICU, and ventilator surges. So if we want to get the models right, we need to know these numbers, in other words. And they pointed out that COVID-19 patients often present with influenza-like illness. And they also observed that there was a surge in non-influenza illness above the seasonal average starting the first week of March, which correlated with known patterns of SARS-CoV-2 spread through the states. And they suggested that this was unlikely due to some other endemic respiratory pathogen or pathogens, and yet it was orders of magnitude larger than the number of confirmed COVID-19 cases reported. And so there was this huge discrepancy in the data. They tried to determine why that might be. So they quantified excess ILI patients in March in the US relative to previous years and compared that to confirmed COVID case counts. By doing this, they estimated that the syndromic case detection rate of SARS-CoV-2 is about 1 out of 100, assuming that all these extra cases were due to SARS-CoV-2. In other words, for every one case reported, there are 99 additional cases out there that were attributed to something, to other, to influenza-like illness in general, as opposed specifically to COVID-19. So this corresponds to at least 28 million presumed symptomatic SARS-CoV-2 patients for the 3-week period of March 8th to March 28th. So let's see what just happened with my slide. There we go. So they observed also this ILI surge may represent a second epidemic of non-seasonal pathogens. So this is one of their assumptions in the paper, that they're pointing out that this could be a flaw in their findings. However, again, that doesn't seem particularly likely, and certainly no other such viruses have been identified to be able to account for this. And they also point out they possibly have underestimated these numbers due to changes in health behavior. So specifically, there's fewer people going to hospitals for milder illnesses. So in past years, people even with just mild illness would have gone to the hospital. They're presenting with flu-like symptoms, and they would go to the hospital. Whereas now, with the SARS-CoV-2 pandemic happening, people with milder illnesses are opting to stay home. They don't want to go to the hospital and risk, becoming more exposed and having an even higher dose of exposure. And so, just the more severe cases are ending up in hospitals. So their findings suggest that confirmed case counts represent only 1% of symptomatic cases. We have to keep in mind that this is just talking about symptomatic reported cases. So there's an additional number of unreported and also asymptomatic, which include asymptomatic cases. Which implies that hospitalization and fatality rates underlying the models are orders of magnitude too high. The Economist reported on this study on April 11th, and you'll note that I was just citing a version of this preprint study published April 14th. The Economist was looking at an earlier version of it that was published on April 3rd. But they point out that, quote, the paper reckons that 7 million Americans were infected from March 8th to 14th, and official data show 7,000 deaths 3 weeks later, because there's a lag in deaths compared to reported cases. And, quote, the resulting fatality rate is 0.1%, similar to that of flu. And if these findings are correct, the Economist noted, it suggests that, quote, New York's hospitals are overflowing because the virus is so contagious that it has crammed the equivalent of a year's worth of flu cases into 1 week. This is a very important point because it helps to explain why hospitals in Italy, in New York, why the capacity in New York came to that came right up to the edge there in terms of capacity. It's not because this virus is just inherently deadlier, or at least not much. It appears more deadly than influenza. It has more to do with the fact that we're a naive population. So it's the contagiousness. So when we're talking about, when they're using this word contagious here in this sentence, they're not talking about SARS-CoV-2 being inherently more transmissible than influenza. In fact, from what we know, it's transmitted much the same way as influenza, mainly through droplets from coughing and sneezing or direct contact. And so when they're talking about contagiousness, they're talking about the fact that because we're a naive population, the reproduction number, that R naught figure, is very high. And so it's very transmissible in that sense. And of course, again, as we develop population immunity, that number will come down. So that's what's happening. That explains why there's this surges of cases that have overwhelmed or nearly overwhelmed certain hospitals, and mainly in strictly as far as I have seen in very highly populated locations where conditions are not generalizable. This is another important point. We can't generalize from those areas to the entire rest of the population around the world in every location. That's just scientifically invalid. Specifically, particularly in northern Italy, the deaths that have occurred there were there was a very unique situation in terms of that population just having very high proportion of people with risk factors. In fact, numerous risk factors. So the economists presented this helpful graph to kind of illustrate what the significance of this paper's findings. And they point out that if COVID-19 has spread faster than commonly thought, if that reproduction number was greater than originally estimated based on, again, mainly PCR assays, then it must be less deadly. This is just a logical truism. And so this chart shows that. So if you look at the top, they show daily cases, new daily cases, and the bottom one shows new daily deaths. And the blue line is the faster growing but less deadly epidemic, and the gray line is the slower growing but more deadly epidemic. So the gray line essentially represents what the assumptions have been and what the models were essentially projecting, whereas the blue line represents what the findings of this paper were. So you can see that with the faster growing and less deadly epidemic, that at the bottom graph, how flat that curve is in terms of new daily deaths in comparison to what the assumptions had been in terms of modeling. And they're not referring to any specific model here as far as I'm aware, but they're just comparing these assumptions. And note that they also point out that both scenarios in the bottom graph match the daily official deaths attributed to COVID-19 in early April, and then they diverge. So both of those lines are consistent with the actual numbers of reported deaths. However, only the blue line is consistent with the findings of this study. Another preprint study titled COVID-19 Antibody Seroprevalence in Santa Clara County, California. This is a very important, just brand new study. It was published April 17th. This was a team of Stanford researchers that included John Ioannidis. And they pointed out that, quote, the measures adopted to slow the spread of COVID-19 were justified by projected estimates of healthcare system capacity and case fatality rate. These projections suggested that in the absence of strict measures to reduce transmission, the COVID-19 pandemic would overwhelm existing hospital bed and ICU capacity throughout the United States and lead to over 2 million deaths. So they conducted randomized serological testing among the general public in Santa Clara County, California. So serological tests had become available. And so they looked at the manufacturer's data in terms of the reliability of the test, but they also validated the test by doing their own testing on it to validate it. And it's a little unclear to me whether there was any false positives, because they do report that a certain number appeared to have been, the number of positives was less than the number that they knew were positive. But they didn't clarify whether that was because it was a false positive or because it was just it was an invalid test. So they did refer to invalid test results. So that it wasn't clear to me. However, they did make clear that they found that there was significant false negatives with this test. So in other words, if anything, the serological testing was undercounting actual infections. So adjusting for population and test characteristics with possibly up to 30% false negatives, they estimated a prevalence in the county of 2.5% to 4.2% infection rate. This implies that the number of infections is 50 to 85 times greater than the reported number of lab-confirmed cases as of April 1st, which corresponds to an infection fatality rate of 0.12% to 0.2%. Again, much more comparable to influenza than to the fatality rates matter-of-factly stated to the public and to policymakers by the WHO and by Anthony Fauci in his testimony to Congress. This further implies that the models that have been used to justify extreme lockdown measures were fundamentally flawed and over-exaggerated the severity by orders of magnitude. And again, this isn't to say that the hospital capacity is not an issue, but again, that's not inherently due to this virus being more deadly. It has to do with the reproduction number and the contagiousness in terms of the reproduction number. And so molecular biologist Andrew Bogan in the Wall Street Journal made that same point. He said, this is not to deny that COVID-19 is more serious than influenza. But he goes on to say, quote, yet if policymakers were aware from the outset that the COVID-19 death toll would be closer to that of seasonal flu than the millions of American deaths predicted by early models dependent on inputs that now look inaccurate, would they have risked tens of millions of jobs and livelihoods? The science to support better modeling and decision-making is rapidly becoming available. One hopes that it will inform better policy decisions. A final paper to look at here, another preprint published April 20th, and I'm looking at, it was published earlier than this in other versions. I was looking at the most recent version. And titled The First 3 Months of the COVID-19 Epidemic. This was done by, I believe, some German epidemiologist. And he noted that extreme social distancing measures can reduce the reproduction number, but at the cost of reducing herd immunity, thus increasing the likelihood of a secondary epidemic wave. So this also must be taken into consideration. So we don't know, just because, for example, a country might come out of it now and reduce case numbers now and death numbers now, daily deaths, doesn't mean that when they let up the policies, there's not going to be a resurgence, precisely because of the prevention of herd immunity. Talked about that in video 2. So they argued, or he argued, that measures should not be indiscriminate, but should target those at high risk. In other words, don't just shut down the whole economy and put people out of work and prevent them from being able to make a living. So the effect of extreme lockdown measures is to increase the duration of the epidemic and prevent the population immunity among the young that's necessary to protect the elderly once they come out of isolation. And note that his finding in this regard is consistent with the projection of the Imperial College model, which here again, I talked about this in detail in the second video, the prior one I made, where according to their own projection, once those measures are lifted, there's a resurgence of cases that actually is worse, it overwhelms hospitals even worse than had the UK simply maintained its original policy in the first place before reversing course as a result of this paper. And so again, the details of that are in that other video. So the German epidemiologist, he presented this interesting comparison. He's talking about 3 Scandinavian countries, Norway, Sweden, Denmark. And Sweden stands out because, unlike its neighbors in other countries in Europe, in the US and elsewhere around the globe, it did not implement extreme lockdown measures. They did issue social distancing recommendations, reasonably so, but they didn't just shut down the economy. And so you can see that it appears that Sweden also, just like its neighbors that did implement more authoritarian measures, has reached the peak. This remains to be determined, but it does appear that it, like its neighbors, it's reached a peak and is on the decline in terms of the epidemic. You will note that Sweden, the blue lines represent reported cases, whereas the red lines represent daily deaths. And so defenders of these policies will point to Sweden and say, well, look, it has a higher reported fatality rate, and a higher fatality rate per capita than its neighbors, which is true. It does have a higher death rate per capita. But one of the major factors driving that higher rate is a large number of deaths that have occurred in nursing homes and elderly care homes in Sweden. And the government there has acknowledged that this has been a failure. They don't quite understand why. They're going to do an investigation, they said, because they did issue recommendations that, care centers did not allow visitors. It also, of course, that the staff should take appropriate precautions, including, obviously, if any staff are sick, that they should stay home. So they don't know what happened, exactly why this occurred. But if you think about it, the extreme, like stay-at-home orders, effective house arrest, unless you're going to go out for something essential like food or exercise. That's the case here in Michigan. These type of extreme policies are really irrelevant to this specific case. They just don't apply. It was other factors driving, this high rate of death among the nursing homes. And so that's one factor. But another thing to consider, again, is going back to the Imperial College model's own projection, that Sweden has implemented a policy that a consequence of it will be that their population is going to have must have developed quite substantial population immunity. And so they don't need, they don't have strict measures that they need to lift. They never shut down their economy in the first place. And so in the other countries, once they, lift these measures, what's going to happen? There's going to be another wave of another surge in cases. And so that's, again, we need to take that into account. So, the total death rate, if in time, we could project that it might be pretty equivalent between these countries. Because again, in Sweden, the second surge won't be as bad. They won't have as many cases. They won't have as many deaths because they have population immunity. So looking again, this is another graph from Sweden of the daily new cases. You can see that it's not exponential growth. They've plateaued, and they appear to be have already peaked. In an interview with Nature on April 21st, Anders Tegnell, who is an epidemiologist at Sweden's Public Health Agency, who Nature described as the architect of Sweden's strategy for dealing with the epidemic, pointed out that, quote, "Close down, lockdown, closing borders, nothing has a historical scientific basis. Each country has to reach herd immunity in one way or another, and we are going to reach it in a different way." So in other words, they're going to reach it by allowing the population to develop herd immunity. Now, to be clear, this is not their stated policy. Their policy is not we want to develop herd immunity. But that's just a natural consequence of their policy. Whereas, again, going to the Imperial College model, their whole end game is we need to keep these lockdown measures in place until a vaccine is developed. So it's a faith-based policy. Another model was the Institute for Health Metrics and Evaluation, IHME, in the University of Washington. And my understanding that this is a Gates Foundation-funded organization here. And this was what they projected on April 1st. I took a screenshot on April 1st of their projection. And notice that they're assuming full social distancing in this model. So they factored that in. They factored in the social distancing policies. And they projected that it would peak. The peak resource use would happen on April 15th. And their estimate was that there would be more than 262,000 beds required, more than 39,000 ICU beds, and more than 31,000 respirators. So a few weeks later, this was their projection. So on April 17th, their projection corrected for the actual data that had come to light, and pretty close in terms of their estimated peak. They say that it had already happened on April 14th at this time, that was the peak resource use. And their downward revised projection was that there would be fewer than 67,000 beds required, fewer than 19,000 ICU beds, and fewer than 17,000 respirators. Again, just to go back and just compare those numbers again. So, in summary, government health officials and the mass media have broadcast fatality rates to the public based on PCR assays that do not detect prior infection and for which there was strong ascertainment bias. Influential models input assumptions about hospitalization and fatality rates on the same basis without knowing the true prevalence and therefore without knowing the true reproduction number or hospitalization and fatality rates. These measures were faith-based, not science-backed, with no clear exit strategy apart from hope that a safe and effective vaccine can be rapidly developed and distributed globally. And these measures, the extreme lockdown measures, hinder the development of population immunity. Oh, the slide order was mixed up there. Another point that the numbers are therefore inherently overestimated. The measures are also causing extraordinary economic harm. We need to take that into consideration. And it's not just, again, it's not just about the economics. It's also that this will take an incalculable toll in health and lives. So it's not money versus lives, it's lives versus lives. And these authoritarian measures also set dangerous precedents with grave implications for respect by governments of individual liberty. The sensible path forward is for extreme measures to be lifted and for reasonable, science-backed social distancing recommendations to be retained, thus enabling those at lower risk to go on making a living. This would not only enable the economy to get up and running again, but also enable the development of the population immunity required to enable those with known risk factors to get on with their lives too. So eventually they could also come out of isolation and enjoy their quality standard of living only because of population immunity. So, if you appreciated this and would like to see the prior videos or keep up with the future videos, I'm going to be publishing these all my videos on the SARS-CoV-2 response at jeremyrhammond.com/coronavirus. While you're on my site, make sure to get on my mailing list and stay updated with my work. So you can go to jeremyrhammond.com/FDA, and there you can download a free report on the FDA titled 5 Horrifying Facts About the FDA Vaccine Approval Process. And so you can get that report and get on my mailing list at that URL. And also, if you valued this video and you found it highly educational and helpful, and you have the means and you want to support me, you can go to jeremyrhammond.com/crowdfunding, because I do rely on reader donations to be able to do this kind of research and empower you with this kind of important knowledge. So head to my website, stay up to date with my work, and thank you for your attention.